Okay, welcome to Chapter 12, Part 2 of Adult Onset Disorders. Okay, we're going to talk about complex or multifactorial disorders. And this is where you have, remember, with complex disorders, it's a multifactorial disease, which means it's due to a large number of genes, each exerting a small effect, and then combined with the environment triggers that manifestation, the phenotypic, the expression of the disorder. Okay, and these complex disorders are top causes of morbidity and mortality in adults. So we're going to discuss diabetes mellitus type 2, gestational diabetes, and obesity. So diabetes mellitus type 2 is characterized by persistent hyperglycemia, and the end result of this over long term is organ damage, microvascular complications, and macrovascular complications. In this type of diabetes, there is a decrease in insulin sensitivity. So that means there's a failure of the insulin to bind to the insulin receptor. And then, of course, there's a change in the cell's permeability to glucose. Diabetes mellitus type 2 is the most common type of diabetes mellitus, accounting for 90 to 95%. The symptoms appear gradually, which limits early diagnosis, and those microvascular changes result in the retinopathy and the neuropathy that we're all familiar with. Nearly 8 million people in the United States have undiagnosed diabetes mellitus type 2 is the estimate. This does run in families. There is a genetic predisposition to it, but again, you need that environmental component for the disease expression. Okay, it does not follow a simple Mendelian inheritance. Monozygotic twin concordance, okay, those are identical twins, of 60 to 90%. So that means that even though there's a predisposition, if one identical twin has it, then it doesn't necessarily mean that the other identical twin will have it. There's got to be that environmental component, okay? And dizygotic twin concordance is 30%. Remember, dizygotic twins are fraternal twins, and they're no different than normal sibling relations. So their concordance is much less than the identical twin. More young people are being diagnosed as a result of obesity and sedentary lifestyles. Those are the triggers, the environmental triggers for that. So genetic risk, if one parent is diagnosed with diabetes mellitus type 2 after age 50, there is a 1 in 13 risk to the offspring. If one parent is diagnosed before the age of 50, there is a 1 in 7 risk to the offspring. And if both parents are affected, there is a 50% risk. Okay, and here's just a table of the fasting glucose values in the diagnosis of the diabetes. Okay, there are candidate genes associated with diabetes mellitus type 2. So there's, like we said in the first slide, there's multiple genes that are a factor here. Okay, and they each exert a small effect, and each gene it varies between racial backgrounds as well. For example, the calpain-10 or the CAPN10 gene, that is important in the onset in 40% of Mexican Americans for the onset of diabetes mellitus type 2. And then you can see in Caucasians, there's a different gene that seems to be the predominant factor in Caucasians for development of diabetes type 2. And there is the ATP binding cassette subfamily C member, ABCC8, and that controls the release of insulin and glucagon. So you've got all these, here we've got 3 different genes that all play a role in the development, and with certain specific risks depending on the ethnic background of the individual or the genetic makeup of the individual. The variations in those causes and the genes that affect how the patients respond, their risk for diabetes, it also affects how they might respond to anti-diabetic medications as well. In addition to these genes increasing their disease risk for the disorder, it also plays a role in how well they respond to their anti-diabetic medications. And recall that almost 70 genes increase susceptibility for type 2 diabetes. And so they're specific to certain populations, and those were just a few examples on that previous slide. Okay, so gestational diabetes is confirmed with an oral glucose tolerance test that's required for all non-diabetic women to take at 24 to 48 weeks of gestation. Gestational diabetes mellitus complicates about 9.2% of pregnancies. It is often noticed around week 28. If it's discovered earlier than 24 weeks, that may be an undiagnosed diabetes mellitus type 2 that was actually there that wasn't known before. And about 90% of women with gestational diabetes mellitus do develop diabetes mellitus type 2 later in life. Okay, there are some chromosomal syndromes that are associated with diabetes mellitus that increase their risk of diabetes. And those would include, as we talked about in Unit 1, Down syndrome, Prader-Willi syndrome, Turner syndrome, Klinefelter syndrome, also single gene mutations, the Modi types. There's several Modi types. We discussed the Modi types, so that also is associated with a type of diabetes. And then the Rabson-Mendenhall syndrome. Okay, so that is mentioned in your book, but it's not really explained. So I will just give a little brief on that. That is a rare autosomal recessive disorder, and it is characterized by a severe insulin resistance. So here there are mutations in the insulin receptor gene. In this syndrome, there's also growth abnormalities in the head, face, and nails. But certainly that is another one associated with development of diabetes mellitus as a component of it. Okay, so obesity, moving on. Overweight is a body mass index of greater than 25. Greater than 30 is the definition of obesity. And 70% of the United States population is either overweight or obese. Genetics account for about 40 to 70% of the variation in the BMI. There are candidate genes with obesity as well. So here the top one, the melanocortin-4 receptor, or the MC4R, controls regulation of food intake and energy balance, and the prohormone convertase is regulation of energy metabolism. Then we have the brain-derived neurotropic factor, which controls appetite regulators in the brain, and then adrenergic B3 receptor genes, thermogenesis and regulation of lipid breakdown. So you've got a lot of genes that if altered, can play a role in a person's predisposition for obesity. And the BDNF is found more commonly in African Americans and Hispanics. And the ADRB3, one variation of this gene was found to be associated with a higher BMI in East Asians, but not in other populations. And the PCSKI is it's rare. People with rare mutations of this gene suffer from an extreme form of childhood obesity, and there's a correlation with obesity in Caucasians with this gene, but not in Asians. So there's a lot of variability there. Okay, autoimmune disorders. Systemic lupus erythematosus, or SLE, multiple sclerosis, rheumatoid arthritis, Alzheimer's disorder, age-related macular degeneration, and age-related hearing loss. All right, so we all know that there's a genetic predisposition, and then again, that environmental component or trigger, most commonly being a virus that does trigger these autoimmune disorders from expressing their phenotype, or expressing or manifesting into the full disorder once there's been an environmental trigger. Okay, so immune system complexity is involved in autoimmune disorders. The self-tolerance is not completely understood. The body must be able to accurately and consistently distinguish self from non-self cells. So there are differences in how men and women are affected. Okay, autoimmune disorders are greater in women. So we're going to start with lupus. The classic symptom is that butterfly rash. Also pericarditis occurs, pleuritis, seizures, and it is 8 times more common among women, as most autoimmune disorders are. Lupus usually occurs between the ages of 20 and 45. Women African Americans are affected 4 times more than other races. Okay, and so here is just the chromosome associated with that. Okay, so it involves a human leukocyte antigens on chromosome 6 that helps code for recognition of self. DNase enzymes levels are low in lupus, and the function of that DNase 1 enzyme is to take cellular debris and chop it up to be disposed of. Okay. So gene mutations with low levels of this enzyme interferes with this disposal ability and triggers the autoimmune reaction. Multiple sclerosis is the most common autoimmune disorder involving the nervous system. Here, the myelin coating of the neurons is destroyed by inflammation, which causes demyelination. It has episodes of exacerbation and remission, like most autoimmune disorders. It is most common among people whose ancestors came from Northern Europe. Women, again, are affected 2 to 3 times more than men. There is a likely environmental trigger, usually some kind of an illness or stressor. It is complex and likely due to variations in many genes, so it's polygenic, with risk determined by a single allele plus an environmental trigger component. It does run in families, especially within generations. The human leukocyte antigen genes are important in the onset of this disorder, and it is on the DRB1 14.01 allele of chromosome 6. It was that picture of that chromosome a few slides back. It has been associated, limited exposure to sunlight, they think may be a factor just because of the geographical distribution of MS, okay, in areas where there's not a lot of sunshine. So, polygenic and environmental contributions. The HLDRB1 14.01 is the founder for multiple relatives within a generation versus across generations. And then you've got the other genes that are protective against multiple sclerosis. And so, again, I mentioned usually an illness or a virus triggers it. So if any individuals with a history of mono plus the presence of the DRB1 allele seem to increase the risk for acquiring or manifesting with multiple sclerosis or triggering that onset. And inadequate vitamin D intake seems to increase the risk in susceptible people as well. Okay, so as stated, okay, the HLDRB1 14.01 gene in MS, some genes are protective, but many of African American descent do not have the protective alleles, and multiple sclerosis in these individuals can be very severe in some African Americans, but not in other populations worldwide. So there is a potential genetic difference between ethnicities and people of different races on how much protective factor genes that they have. And vitamin D is interesting that has been correlated with increasing the risk in susceptible people because we know vitamin D plays a role in development and function of the central nervous system and immune systems, and this is an immune system disorder. Okay. There's also evidence that if people with the DRB1 risk allele get mono, that their risk of getting MS goes up, as we've stated. Okay. So that seems to be the main trigger, but of course it could be any viral disease. Okay, rheumatoid arthritis is the most common connective tissue disease. It is chronic and progressive. Tyrosine phosphatase involvement with this one. It does affect primary females as well. Here you have synovitis and production of autoantibodies. And the rheumatoid factors, mainly IgA and IgM, attack tissues in the joints, which cause inflammation. 50% of the risk is genetic, and smoking increases this risk. Okay, there are 30 different regions of the genome that have been associated with rheumatoid arthritis. One gene that has long been associated with rheumatoid arthritis is that protein tyrosine phosphatase, and it is involved in many autoimmune diseases, as well as, in addition to rheumatoid arthritis, it's involved in type 1 diabetes, autoimmune thyroid disease, and also lupus. Okay, so we've already mentioned smoking increases the risk for rheumatoid arthritis. It is the strongest risk factor, with long-term smoking history associated with the most severe rheumatoid arthritis symptoms. So other risk factors: changes in sex hormones, occupational exposures to dust and fibers, and again, viral or bacterial infections. Okay, Alzheimer's disease and cognitive decline. Okay, it's an irreversible disease that progresses from mild memory loss to complete incapacitation. About 50% of cases of dementia are caused by Alzheimer's disease. It does run in families, and it's associated with shortened telomeres. You remember telomeres are those repetitive sequences of DNA at the tips of the chromosomes. Okay. Early onset is considered ages 30 to 60, and that accounts for 1 to 6% of Alzheimer's patients. It is autosomal dominant. The associated genes are the amyloid precursor protein on chromosome 21, the presenilin 1 on chromosome 14, and the presenilin 2 on chromosome 1. Mutations in any of these genes increases beta amyloid protein, which forms much of the associated plaques of this disorder. Okay, so late onset Alzheimer's disease is that occurring after age 60. It is complex and multifactorial. The apolipoprotein E, or APOE, on chromosome 19 is involved here. The E4 allele on the APOE gene increases the risk. So probably additional genes are involved, but if one person is affected, primary relatives are twice as likely to get Alzheimer's disease than someone from the general population. So the gene associated with the complex form, again, is the apolipoprotein E, APOE, on chromosome 19. So the EPOE alleles, there's 4 of them. So allele E1 is not commonly associated with AD, with Alzheimer's disease. E2 is less common and may offer some protection against getting Alzheimer's. E3 is most common and does not seem to alter the risk, but the E4 allele presents the highest risk of sporadic Alzheimer's, with 40% developing Alzheimer's disease. Many other potential causes of Alzheimer's are being investigated. Okay, age-related macular degeneration is the most common cause of central vision loss in the elderly. There's deterioration in the retina, which occurs from accumulation of extracellular deposits of drusen. There are 2 types that exist. You've got atropic or non-neovascular and exudative or neovascular. So the genes with a role in the complement pathway may be involved here in the development of macular degeneration. Genes with a role in cholesterol management may also be involved, and smoking increases the risk for macular degeneration. Okay, the atropic type is caused by the breakdown of light-sensitive cells in the macula. 85% of macular degeneration is atropic, and it does progress slowly. The exudative type occurs when abnormal blood vessels grow underneath the macula and leak protein in blood. It's 10% of those affected with macular degeneration, but there is a rapid progression. The risk modification for macular degeneration, it's important to counsel individuals to eat lots of green leafy vegetables, maintain a healthy weight, regular exercise, and don't smoke. Again, smoking is the greatest risk factor for macular degeneration. Age-related hearing loss is associated with over 400 syndromes. About 50% of people over 60 have some form of hearing loss, but there is a genetic risk. Autosomal dominant gene, MYO6, is one that increases the risk. Variations in genes that encode for B and Y actin, and exposure to loud noises, of course, will damage anyone, but genetic risk for that is unclear. It is a complex disorder. Okay. The B and Y actin are proteins that maintain the hair-like fibers in the ear, which convert sound waves into nerve signals. So other genetic contributions, the single nucleotide polymorphisms identified by the genetic studies. There's a list here of different genes that possibly contribute to this hearing loss. Okay. Environmental contributions to hearing loss include ototoxic drugs such as aminoglycosides, aspirin, and loop diuretics, alcohol, tobacco intake, high fat, dietary intake, and exposure to chemicals. Medical condition associated with the with age-related hearing loss would be diabetes mellitus, atherosclerosis, and hypertension. So modifications of these risk factors will also help with decreasing hearing loss as we age as well. Okay, controlling diabetes, prevention of atherosclerosis, keeping your blood pressure down, all those can help decrease a person's manifestation of these conditions. Okay, thank you. If you have any questions, again, please let me know, and I will conclude. Thank you. This is it.